Hello and welcome to this section on FeNO in the management of asthma. My name is Carol Stonnan. I'm a respiratory nurse based in Gloucestershire and I'm Executive Chair of the Primary Care Respiratory Society. So to consider where FeNO fits within the whole asthma pathway for patients, we need to go back to what asthma is. Asthma, we know, is an inflammatory condition that inflames the mucous membranes of the airways that causes swelling into that airway, reducing the airspace, making it more difficult for the patient to breathe. The secondary thing we know that happens is particularly when these airways are inflamed and angry, the muscles that overlie those airways become twitchy and sensitive. And when they come into contact with the patient's triggers can be varied. They can be anything from exposure to pets, to going out into the cold air, to perfume, to cigarette smoke, to infection. You need to talk to your patients about their triggers to help them recognize them. But when the patient comes into contact with the triggers, those muscles tighten, close down further on the airway, and make it even more difficult for the patient to breathe. So how do we assess asthma control? So we generally should be asking our patients, at the very least, the Royal College of Physicians, 3 questions. So questions about daytime symptoms, nighttime symptoms, and exercise limitation, for example, over the last week or month. We may do an asthma control test, which asks a little bit more. So it asks a little bit around the blue inhaler use and the patient's perception of their own control, which is always really interesting. But this is an additional tool that I find really helpful. So this is the Asthma Right Care slide rule. It's very easy to glance at a patient's prescribing history and to see that they've had, say, 8 salbutamol inhalers in the last year and think, well, 8, that's not that many. What this slide rule does is it really helpfully breaks down the number of inhalers in the last year to the number of puffs in the last year to the number of puffs in the last week to how many puffs of salbutamol that patient must be using every day. And it's often quite a surprise to the patient, and it's often quite a surprise actually to the healthcare professional, how much, say, for example, 8 canisters equates to on a daily basis. So if your patient has been prescribed 8 canisters, if they're using them, you can see there, that is 31 puffs per week, which means they're using more than 4 puffs per day, which is an indication of poor control. So we need to think about where we set our parameters when we're looking to find our patients that we consider that may have poor control, particularly when we're using our salbutamol prescribing as our baseline. Often, ideally, you can see there, for a patient to be using 1 or less than 1 puff a day, they should only need to be prescribed 1 or at most 2 canisters in a whole year. If they're being prescribed a monthly canister, that's 12 canisters, then they're using at least 7 puffs a day, and that really needs to be targeted. But this is a good tool for you to work it out quite quickly and quite easily, and for you to open that conversation with your patients. So when our patients that have diagnosed asthma, that are on an inhaled steroid, that present with increasing symptoms, what do the guidelines tell us to do? We turn to the guidelines generally for our advice and our guidance, as we would expect to. But there comes a problem when the guidelines tell us to do different things and we're not sure what is the best thing to do for the individual in front of us. So BTS tell us that if we have a patient that comes in, is on inhaled steroid, that is symptomatic, we should add in a long-acting beta-2 agonist in a combination inhaler. And this can be a MART regime, or it may be a standard fixed dosing regime. We then get our patient back and we review them and we ask if they're better. If they're better, absolutely fine, spot on, continue. If they're not, stop. If they're a little bit better, then we can increase the dose of inhaled steroids, so they're on a higher dose inhaled steroid, but still keeping it in that combination inhaler, or we can add in a leukotriene receptor antagonist, so something like montelukast, you've not much choice there. And if that doesn't work, then we should refer to a specialist. So that's a little bit touchy-feely. NICE give us different advice. So NICE tell us that if a patient comes in and they're on an inhaled steroid, and they're having increasing asthma symptoms, we should add in a leukotriene receptor antagonist. We should review and see if they're better. And if they are better, we can continue. If they're not, we can stop it. And if they're not better, then we need to do something else. So at that point, we add in the long-acting beta-2 agonist, and we do that in a combination inhaler. We can try a MART regime. And if that doesn't do the job, then we can add in inhaled steroids or something else. So something like LAMA or even theophylline. But at that point, we should be considering asking for specialist advice. So that leaves you a little bit between the devil and the deep blue sea, knowing, okay, so which one do I follow? What do I do first? Do I add in a long-acting beta-2 agonist, or do I add in a montelukast, which will act on the inflammatory pathway? So let's think about a patient. So this is a fictional patient, we'll call him. His name's Hugh, he's 47 years old, he's had asthma since he was 27. He uses a Clenil inhaler, so an inhaled steroid, and he uses 2 puffs twice a day. And most times he uses his air chamber, but not always. He's a non-smoker, but over the last 6 weeks, his asthma symptoms have been getting worse, and he's even been waking at night occasionally with his asthma. He's needing to use his rescue inhalers most days, but this is a routine appointment. So he's coming for his routine review, and this comes up in conversation. So if we look at the BTS guidelines tell us to add in a long-acting beta-2 agonist, to review and continue if it's effective, stop if it's ineffective, and increase the inhaled steroid, and if partially effective, increase the dose of inhaled steroid in the combination inhaler. Now, if you have a patient that's needing to take their rescue inhaler most days and you add in a long-acting beta-2 agonist, then you would expect your patient to at least be a bit better. Okay, so I would be surprised if this patient came in and said they were no better. You then further review, and if you still not achieve control, then you add in a leukotriene receptor antagonist. It is a bit sort of try this, and that's how we have practice asthma, because not all asthma is the same. Not all patients need the same treatment, not all patients will respond to the same treatment. So we need to try and be a little bit more precise in our care of our patients, and we need to try and target the medicines to the symptoms and the way the patient is presenting. So how do we do that? Do we measure the obstruction in the lungs? Do we do spirometry? Would that be useful or not? Or do we look at FeNO, which will measure the eosinophilic airway inflammation? Or do we do a combination of both? And often it's a time constraint that would limit one or the other. Now, we know that FeNO is a biomarker for allergic airway inflammation. We know that it's driven by the whole allergic process that underlies the mucous membrane, and it's driven hugely by eosinophils. And we know that the higher the eosinophilic airway inflammation, the higher the nitric oxide production will be, the higher the FeNO result when you check that in expired air will be. So there's a direct correlation between a raised FeNO and underlying eosinophilic airway inflammation. So back to our patient. So we do spirometry and it's normal. So his FEV1 is 90% of what we'd expect it to be. His ratio is 78%. And we're assuming that will be okay, bearing in mind it's not 100%. It's not obstructive. We check inhaler technique, which we will always do when we see a patient. So his inhaler technique is good. He's got good adherence. So he is actually using 2 puffs twice a day most of the time. And there's nothing new in his life that started this off. No new pets, no new job, no new house, nothing to set this off. But when you talk to him in detail, he does tell you that actually this happens quite commonly following an upper respiratory tract infection. So if he gets a bit of a cough and a cold, it just drags on for weeks and weeks and weeks. But this time, interestingly, there was no acute upper respiratory tract infection. And when you measure his FeNO is 72 parts per billion. So what does that mean? In patients with established disease, FeNO is really useful. And I find these 3 categories really useful. So if you have a patient that has increasing symptoms and you measure their FeNO and it's below in an adult 25 parts per billion or 20 in a child, that tells you that that patient has not got active airway inflammation. It tells you that the driver for those symptoms is not inflammatory. So increasing the anti-inflammatory treatment will not be helpful. In that case, adding in a long-acting beta-2 agonist is exactly the thing to do. If you go to the other extreme, to the raised FeNO, so that's over 50 parts per billion in an adult and over 35 in a child, there are a few things that can be happening here. So it might be that the patient has the inhaler but isn't using it or isn't using it properly. So you need to really be clear that their inhaler technique is good and their adherence is good. If you're happy that is the case, then these are the patients that need additional anti-inflammatory medication. And that may be in the form of an increased dose of inhaled steroid, which is effective. And sometimes it's a case of adding in the montelukast. So that gives you a bit of a guide as to what you do with your patient, the patient in front of you, how you apply those individual guidelines to the patient in front of you. There's always that problem area in the middle, those intermediate results. So I would consider that 25 to 50 in an adult, 20 to 35 in a child. And then you can really focus in on what it is that's causing the problem. So again, it may be that the patient has a device that they can't or don't use properly or can't or don't use regularly. But it may be that actually genuinely there is underlying airway inflammation and an increased dose of inhaled steroid is exactly the thing to do. So I would look at where they are in that range, look at the other things that are happening, look at the way they're presenting, and think about, this is where the phenotyping sort of comes in and the personalised medicine. Think about what it is you think is best for that patient, given the whole picture, not just the FeNO result. So it's a really good guide for those patients that are symptomatic, that are on treatment, and you need to know what to do next. So let's think about another patient. So this is Poppy. Poppy is 17. She's had asthma for as long as she can remember, since she was a young child. She joined the practice a few months ago, and since she joined your practice, her symptoms have been increasing. She has a Clenil inhaler, she takes 2 puffs twice a day, and she tells you that her asthma is usually well controlled. So what do the guidelines tell us? The guidelines tell us before initiating a new therapy, we should be checking compliance with existing therapy, inhaler technique, and where possible, eliminating trigger factors. So back to the basics and do that before you do anything else. So Poppy's FeNO was 124, which, given the slide I just showed you saying that if a FeNO is over 50, that means the airways are inflamed. This means Poppy's airways are really inflamed. She's 17, she's quite a slight girl, but she's taking 400 micrograms of inhaled steroid every day. So what's going wrong? Where's the problem? This is a really good opener into that whole conversation around adherence, concordance, compliance, whatever it is you want to call it. Is the patient taking the treatment as you think they are, as they tell you they are, or as it's prescribed? As it's prescribed can be difficult in asthma because we often adjust prescriptions and we often do it verbally, but it's worth asking the patient. So how can we check whether or not a patient's taking their inhaler? We can check what they're being prescribed. So we can see that they're being prescribed or not. They're inhaled steroid regularly, and we can see how much of their blue inhaler they're being prescribed. We can ask them, we can say, do you take your treatment regularly? But do they always tell us a sort of a wholly truthful answer, or do they tell us what they think we want to hear? So this is an interesting study that really demonstrates that FeNO is a really good tool for detecting non-adherence in patients with their inhaled steroid. If you look at the FEV1, whether patients are taking their inhaled steroids well, whether they're not taking them at all, whether they're taking them a little bit, FEV1 is pretty static. There's no indicator there about whether a patient's taking their inhaled medication. But when we come to FeNO, so bear in mind, FeNO detects eosinophilic airway inflammation, and if patients are not taking their inhalers properly, the inflammation breaks through. FeNO is a really good tool for giving us an indication as to whether or not patients are using their inhalers. So if you look at good adherence, the FeNO is nice and low, and as the adherence gets worse and slips, then it rises up and up and up. And then you can see with the control group are non-asthmatic volunteers that are nice and stable as well. So a tool that is very sensitive to picking up non-adherence in medication in their inhaled steroid really quickly. So Poppy was really interesting. It turned out she wasn't taking inhaled steroid at all. And the reason she wasn't taking it is because every time she took it, it made her cough. She'd relied on her bronchodilator for many, many years. It's the way she managed her asthma. And that, we know, is a really risky strategy for people with asthma. And actually, on closer questioning, even though in the sort of surface conversation, when I said, how is your asthma? She said, it's good, it's never a problem. When I asked about specific symptoms and the frequency of specific symptoms, we uncovered the fact that she's had poor control for many, many months. And she'd never been asked those detailed questions about her asthma before. She'd always got away with a very superficial asthma review in that, how's your asthma? Oh, it's fine, good. And off she went. And she was indeed collecting her brown inhaler regularly. The difficulty was Poppy's dad also had asthma, and she was claiming the prescriptions. She's a student, she was not paying for them, and her dad was using them. So at first glance, looking at the prescribing information, it looked as if Poppy had really good medication adherence, but in actual fact, she was taking nothing. So having taken the time to explain to Poppy what her asthma is, the airway inflammation that underlies asthma, measuring and demonstrating that to her using FeNO, and getting to grips with what the problem was. The problem was this inhaler that made her cough. We changed the inhaler to a different inhaled steroid, showed her how to use it. She convinced me she could use it well. She agreed that she would try to use it a couple of times a day, so once in the morning, once at night, for a few weeks, just to see how things went. She came back to see me a month later, and her FeNO had dropped to 44. So from 120 something down to 44. Really good drop. It drops really quickly with treatment. And more importantly, she was feeling great. Looking back, she could see just how awful her asthma had been for so many months. And she'd got to the stage when she came in to see me where she'd had to stop playing hockey and she'd had to ask somebody else to groom her horse because she couldn't be near her horse. And she'd got back to playing hockey and she got back to riding her horse again. So she was really happy with the treatment outcomes. So I think another category of patients we need to think about are the patients we might consider stepping down treatment. If we've got a patient that's been stable on a dose of inhaled steroid for months and months and months, then we need to consider stepping down. But that's often quite a difficult conversation. It's difficult for the healthcare practitioner. It's difficult for the patient. Nobody really wants to rock the boat, and it's how do you go about doing that? So firstly, you need to review your patients to do that. If you don't see your patients, you obviously can't talk about medication. And the aim is to maintain the patient on the lowest possible dose of inhaled steroids that controls the symptoms. And we know that the reduction should be very slow. We know that sometimes when we drop a dose down, the patient has marginally increasing symptoms. So it's about explaining that to your patient in advance and telling them what to do if that happens. And it's about thinking in advance when you're going to do this. So if a patient comes in and they've been very, very well for months, they've had no exacerbations, they've had minimal rescue use, they're feeling really good, then you need to look forward as well to see whether or not this is a really good time to step down their dose of medication, because we don't want to step down the dose of medication as they go into a time of year that is high risk for them. So it may be hay fever season. It may be children going back to school after the holidays. It may be that somebody's got something really important coming up, like they're getting married or they've got exams coming up. So it would be sensible to just wait until those times have passed, and certainly not sensible to step down medication when you know a patient's going into their trigger time. And FeNO can be a really good tool to give you and the patient confidence that this is a really good time to consider reducing their dose. And again, I find the 3 levels really useful. So if I've done FeNO on a patient and it's low, so below 25 for adults, 20 for children, as long as they genuinely are asymptomatic, they are feeling really well, they have been for at least a good 3 or 4 months, they're not going into troublesome period, this is a good time to consider stepping down their inhaled steroid. If a patient tells you that they're well and they're not having any problems, but you check their FeNO and it's in the red zone, so it's above 50 for adults or above 35 for children, you need to really find out what's going on with this patient. So you need to really talk about symptoms. You need to really talk to them about future risk of exacerbation. And this would not be a good time to reduce their inhaled steroids if their airways are already inflamed. And again, that middle section, these patients are have potentially uncontrolled airway inflammation, depending on where they are. So I would suggest that you monitor these patients, get them back, check their inhaler technique, check their adherence to the medication, get them back maybe a month later and see where they are there, because one static measurement in time may be rising, maybe falling, or maybe static. So in those intermediate patients, I would certainly suggest you don't reduce their medication, but you get them back in maybe a month to see where they are, to see whether that FeNO level's risen, dropped, or is static, and go from there. And this is a study, only looked at a small number of children, so it's 40 children. And what they did was they used FeNO as a way of anticipating or predicting high risk of relapse in asthma when they reduced doses. So they checked their FeNO measurements at 2 weeks, 4 weeks, 12 weeks, and 24 weeks after withdrawing ICS to see exactly what happened with these children, see if you could predict where the problem was. And you can see quite clearly that in the relapse group, the baseline was normal, nice low FeNO for a child. At 2 weeks, there had been a considerable rise, and it continued to rise at 4 weeks. These are the high-risk patients that are very likely to have relapse. And it's a good test with a combination of sensitivity and specificity for asthma relapse. So if you withdraw or you reduce their inhaled steroid, check their FeNO a few weeks later to see what's going on. If you compare those to the group that didn't relapse, you can see their FeNO stable. You can see that by reducing their inhaled steroid, the airway inflammation did not reappear, so they're not at risk of asthma relapse or asthma symptoms. FeNO is a really useful tool for different parts of asthma management. It's really useful for helping to confirm a diagnosis of asthma. It's really helpful for that conversation and that pickup around adherence or non-adherence with inhaled steroids. We know that, as I say, FeNO measures eosinophilic airway inflammation, which we know is very susceptible to the effect of inhaled steroids. And you can measure that inhaled steroid response, so you can show your patient exactly what their inhaler is doing. And it's also really helpful for considering the patients that may go on biologic therapy and then for monitoring them throughout their journey. So it's a really flexible tool for the whole of the asthma pathway. So to go back over what we've just done, we know FeNO objectively measures eosinophilic airway inflammation, and that this is really helpful for deciding which treatment you add on to patients that have symptoms from their asthma. It's also really helpful for picking up maybe why that may be, why they may have increasing symptoms. So that conversation around non-adherence with inhaled steroids. And then at the other end of the spectrum, it's really helpful for guiding step down of asthma medication. But the thing I find really helpful with FeNO in asthma is that this tool really helps patients to understand exactly what's going on and to work out for themselves almost when their symptoms are worse, what will be going on and what action they should take according to their personalised asthma action plan to help control that. It's a really good tool for giving that light bulb moment for patients to really grasp that whole situation. I hope you enjoyed that session. Thank you for joining us, and we'll see you again.